Good morning, everyone. My name is Gustavo Saposnik. I'm the editor-in-chief of the World Stroke Academy for the World Stroke Organization. Today, we have the privilege to have two experts in the field and the authors of a big e-learning module of big data and machine learning. We have Dr. Adriana Conforto. She's a professor at the Hospital Israelita at the University of São Paulo, and Alexander Diaz Porto Chiavegatto Filho. He's an associate professor at the School of Public Health at the University of São Paulo. So thank you very much for joining us, Adriana and Alex. Did I forget any other hats? Are you holding any other position? Please go ahead, Adriana.
I'm currently co-chair of the research committee of the World Stroke Organization.
Thank you for having me. I'm an associate professor in the field of machine learning healthcare here at the University of São Paulo, and I run the Big Data and Predictive Analytics Lab here at the School of Public Health.
Excellent, thank you. So, let's get started. Quick question. Why do we need big data and machine learning?
I think that we do need it because healthcare is the most complex and difficult area in the whole world. So it's the field that probably has more complex interactions within its factor, leading to the final results. In our case, for example, death or a serious disease and so on. It's usually a very complex interaction between many factors. And by collecting this data, the algorithms are able to really understand the details behind those interactions and improve healthcare decisions because, as we all know, they are very hard, and it's literally a matter of life and death, especially in developing regions of the world where we do not have enough exams, where we do not have enough physicians, and so on. Those algorithms can really improve healthcare provision in those areas.
Thank you, Alex. And Adriana, why big data?
Yeah, so we know that today most strokes and stroke deaths occur in low and middle income countries, while on the other hand, most research and access to quality stroke care occur in high-income countries. And we have pressing questions in stroke care that are common to all the world. And funding for research involving large data sets with real-world data, as well as huge clinical trials involving different countries, may be challenging. So big data offers the opportunity of gathering real-world data from different sources, from different contexts, and this information can lead to changes in clinical practice. Also, this information can be used to feed machine learning models that can lead to more personalized prevention, acute care, and also long-term care in stroke. But in order to do that, we need to have good quality data and to know how to work with big data so that the value that is aggregated to big data relies on really having actionable insights so that we can really change stroke care.
Understood. That's great. So now imagine I'm a clinician, working in the stroke clinic or in the emergency department. So how can I use, big data or machine learning in the real world of patient care?
You will use it in many forms. So the first of all is to not type anything on the electronic medical records. So the algorithms are going to just listen to your conversation with your patient and are going to record and fill every single part of the electronic medical record. So this will save you a bunch of time. It's already a reality in some hospitals in the US, and it's coming fast here to Brazil and other regions of the world. The second one, you can use it to answer some doubts or some questions regarding the diagnosis and prognosis of these patients. So the algorithms are going to be able to learn with data from thousands, maybe millions of patients regarding, given the characteristics of this patient, the symptoms, which is the patient's diagnosis and which is the gravity of this patients, in the sense of which is the risk of these patients having a bad prognosis in the future. And it's going to help you with the decisions if you're going to keep these patients in the hospital, if you're going to send them or her home, and so on. So it's going to help you in every single moment of your clinical care.
So just to give an example, for instance, let's say you are in the emergency room and you have a patient with acute ischemic stroke. So machine learning using data trained by big data could tell you already, send you an alarm that that patient has large vessel occlusion, for instance. It can already send an alarm to all the personnel involved in the care so that the care can be quicker. It can already gather all the relevant information about that patient, considering history, onset from symptoms, results of neuroimaging very quickly in the same place, and also help you with the clinical decision. So the idea is not to have artificial intelligence to make the decision for the clinician, but to support the clinical decision by providing more information and algorithms that, of course, have to be to undergo criticism so that they can be applied. So by saving time, and we know as stroke neurologists that time is extremely variable, you can focus on delivering efficient, acute, fast stroke care, and also in having more time afterwards for the human interactions, even whether you're in the clinic, whether you have an inpatient, to really be able to continue the human interactions and saving time from administrative or non-intellectual intellectual work, in addition to having quicker stroke workflows.
So something similar, Adriana, what we are using, for example, in the acute stroke care with the algorithm from different companies to analyze the brain imaging and identify perfusion or perfusion mismatch.
Exactly, Gustavo.
So how about this? I'm sharing the screen, and you have probably seen this article. So in this study, as you know, the authors train ChatGPT-4, and they try to identify what's the level of agreement in terms of when ChatGPT recommended endovascular thrombectomy for patients with an acute ischemic stroke, and when the primary care provider recommending that. And as you might have seen that, the interesting part of this, and it's a complicated or something long to read, but the agreement rates were not that great. So I think that it was overall between 40 to 50%. I will scan that so the audience can also take a look of that those numbers. So can you comment on that?
Yes. So I think in this study, ChatGPT-4 was used, and the idea was to compare the decision made by ChatGPT and by expert stroke neurologists in indicating or not thrombectomy. I'd love to hear Alex's opinion on this, but my impression of one of the reasons why the results were not as good as we would like, let's say only a 54% agreement, may rely on the fact that the same prompt question was used for ChatGPT, and it was for each case, the same prompt was used. Because my impression is that the more that you train the algorithm and the more precise questions that you can ask, the better are the results. So to have good results with artificial intelligence, you really have to feed good quality data and to ask good questions. So I think there's still a big opportunity to improve this kind of tool to assist in clinical decision making. So I'd like to know Alex's opinion on this. So.
Yes. So the first of all is that ChatGPT was not trained to answer medical questions. In the future, we're going to have algorithms trained solely on the medical literature, which are going to improve a lot. It's not the goal of ChatGPT to do this. It's not even one of the benchmarks that they use to assess the quality. So it's just a consequence, and people are trying to use it in different areas where it was not trained specifically for. But in the future, we're going to have specifically trained algorithms. So this is the first thing. The second thing is that ChatGPT is version 1.0 of generative artificial intelligence. So it has 1.5 years. There's a technology. Can you imagine a technology that was discovered and then in 1.5 years, we want it to be perfect? That's crazy, you know. So we're very, very, very in the beginning of this technology. It keeps getting better almost every day, literally almost every day it gets better. So we are in the first very early steps of this technology, which, as I said, conversational machine learning has 1.5 years, is 1.5 years old. So I mean, it's very early in the beginning. It's only going to get better and more specialized.
So Alex,
can I add
question?
Something?
Yes, of course. Yeah.
So do you think that, considering that there's still so much opportunity for improvement and that ChatGPT was not intended to be a medical decision support system, do you think how important it is for stroke neurologists and other professionals who have the clinical perspective, who know the questions, who can evaluate medical evidence, to work with data scientists and the people who are going to develop these applications for clinical use?
It's amazingly important. So one thing that we have been finding out in our laboratory here at the University of São Paulo is that the algorithms that make intelligent decisions for patients of one specific hospital do not always work as well in another hospital, right? Because you have different patients, you have different professionals, you have different exams availabilities and so on. So in the end, we're probably going to have very specialized algorithms in order to actually make decisions as good as we want to. So the local physicians of the hospital, we're probably going to have a huge data science team in every single hospital. As today, most physicians discuss clinical cases, probably in the future, they're going to discuss the data science or machine learning mistakes and work with the data science team in order to improve those algorithms in the direction that mostly the direction that the physicians want the algorithm to mostly improve. So it's going to be fundamental for every single physician to have this. And as you said, Adriana, it's going to open up the human interactions for the physicians, right? Because those robot decisions, those technical decisions are going to be greatly improved by the algorithms, but not the human interaction. So human medicine is going to be back, right? Because most physicians are going to have mostly very close decisions and the diagnosis accuracies and so on. What's going to be different is how the physicians transform this technical information into a humane way for the patient, understands the patients, listens to the patients, and suggests the better clinical next steps for each patient.
So a comment and a final question for you, for example, Alex. So my understanding, and based on our previous research and previous the literature, is that humans usually, especially clinicians, when you are making a decision, they can handle 2 or 3 variables when they make a decision, not that many, the interactions of many variables. So this is one of the advantages of, machine learning or using big data to train, algorithms or to create algorithms. But the question is, from the scientific viewpoint, how many data points do we need? So, for example, if we have a data set of 100 patients and 10 data points, so variables, is that enough? Do we need 1,000 patients and 20 or 100 data points? Can you comment on that?
It's a great question, but actually the main challenge is to have important predictors, right? Variables that predict well what we want to predict. You can have millions of data from millions of patients, but if you don't have anything that predicts well the disease or the prognosis you're trying to predict, it doesn't matter, right? Like you can have 100 million information about, for example, what kind of football team the person likes, what kind of color the person likes. This is not going to predict anything in healthcare. Okay, so the most important thing is to have good predictors. We have had some studies here in my lab with only 50 patients, the data from 50 patients, but because we had very strong predictors, we were able to predict very well what we wanted. So this is very promising, even for small hospitals, that you're able to predict well, even if you don't have many patients, if you have the important predictors for this specific outcome.
Because in stroke, we already know what are the most important predictors. Clinical predictors, we have imaging predictors or brain imaging predictors, but you know, it's relatively well known.
Exactly. And then what the machine learning algorithm is going to do is going to analyze and find out the interaction between those factors. As you said, as humans are able to have in our head like 2, 3 interactions and so on, but the machine learning algorithm is able to have dozens and dozens of interactions. So maybe if the patient has this characteristic, but then has another one, it decreases the chances. But then if it has a third, it increases. If it has a fourth, it decreases, and so on. It's able to learn all these very specific details, and it doesn't forget. Doesn't get tired. It's 24 hours ready to answer any questions that the physicians have and so on. So the future is very bright into improving healthcare decisions. And I think, as Adriana also said, obviously it's not going to substitute anyone, and it's going to, in the end, increase the demand for physicians, right? Because physicians are going to give better diagnosis and better prognosis and better interventions for patients. So why would I stay at my place having pain, suffering, and so on, if I know that when I go to this physician that use these algorithms, my problem is going to be solved? So I'm going to go more to the physician, more to the hospitals, and so on. So the future is very bright for healthcare, and it's why we have been seeing such huge investments in data collection and technology in the last few years.
Thank you, Alex. Adriana, any final comments? Is there anything that you would like to add?
Well, I'd like to thank very much the World Stroke Academy for this opportunity. I'd like to thank you, Gustavo, for all the support that you've been giving to this initiative at the WSA. And I think the main message that I'd like to convey is that artificial intelligence does not substitute wisdom, and it does not substitute human interactions. And I think that our medical abilities can be strengthened in the future by using this technology, by using it well.
Thank you both very much for the thoughtful comments and great points that you have made. I hope that our audience also benefit and enjoy as much as I did. Thank you very much.
Thank you very much for having me.
Thank you.